Order. Welcome back to the Public Accounts Committee on Monday the 9th of February 2026. We now move into our second session this afternoon. The way we treat people with frailty is a mark of a civilised society. The NAO estimates that as at March 25, just over 1 million people had been diagnosed as living with moderate frailty, and an additional 450,000 were living with severe frailty. However, the true number of people living with frailty in England is likely to be higher still as the population ages, and the number of those living with frailty is likely to increase. The harmful effect on people's health from frailty not only affects individuals themselves, but also imposes considerable costs on the health care system. So today we'll be looking to challenge the Department, DHSC and NHS England on why GPs are not adequately identifying and providing the required level of support to people living with frailty. We will also be examining why there is significant local variation in the proportion of people being assessed for frailty, and determining who is ultimately responsible for whether GPs assess and provide the needed level of support for people living with frailty. So to help us with that, we have two of our witnesses, principal witnesses, who have been with us already for the earlier session. So, Permanent Secretary, would you, just for the record, reintroduce yourself?
Hello, I'm Sam Jones, Permanent Secretary at the Department of Health and Social Care.
Thank you very much. Sir Jim.
Jim Mackey, Chief Exec, NHS England.
Professor Chris.
Chris Whitty, Chief Medical Officer for England.
Welcome back to the committee. And Dr. Amanda Doyle.
I am Amanda Doyle. I'm the National Director for Primary Care and Community Services at NHS England.
And I think you've attended the committee before, haven't you?
I did.
Yes. Well, welcome to all of you. Now, to start us off with all of that, I think Rachel Gilmore is going to help us.
Thank you, Sir Geoffrey. Sir Chris, how lovely to see you again. And I'm looking forward to you visiting Minehead in my constituency as soon as it can be arranged, because, as you know, my constituency has one of the highest demographics of elderly and poor people in the country. So given your previous reporting on frailty and an ageing society, how important is identifying and supporting older people in the community before they have a health crisis?
Thank you. And so this is absolutely central, because frailty drives a lot of the lack of independence and reduction in dignity that people often feel in older age. And a lot of it can be headed off early on, and the longer the run up at it we have, the better. So actually preventing frailty should start much earlier in age. Nevertheless, once people have got early frailty, if that's identified, firstly it's possible to slow down and in some cases reverse some of the elements of frailty, at least for a period. Secondly, it means that you can work with them to try and reduce the risks that can come from frailty. For example, things like falls, which can be devastating for people because they lose their confidence in older age once they've reached a period of frailty.
It's funny you should say that, because I went to visit my mother in hospital last night, where she fell on Saturday and has just had a hip operation today. So it's very pertinent, although she's lucky enough to be well cared for by her family. But thank you, you're so right.
Happy, Rachel? Thank you. Thank you. I can understand that's upsetting. I can see it's upsetting. So anyway, I hope
my mummy.
I hope she gets better soon. I'm sure she will receive excellent care. Anna, please.
Thank you. So I'd just like to focus on the role of the GP in supporting people with frailty. So since the contract in 2017-2018, it has been a contractual requirement for GPs to identify registered patients over the age of 65 who are living with moderate and severe frailty, and then obviously to put in place a more proactive sort of care plan and make sure that that risk is assessed and managed. It's clear from the NAO report that GPs are not meeting that target and those expectations. Do you know why? And I'm not sure if this is maybe for you, Amanda, or yeah.
It is clear that not enough people are being formally assessed. What happens in practice is that GP practices usually use something like the electronic frailty score that isn't a diagnostic tool for an individual patient, but will risk stratify and identify the patients who should have a more clinically judged approach to assessment, and then those patients who are suffering from moderate to severe frailty should be coded as such, so that we can then find them and put the proactive interventions in place. We don't have a completely clear idea of the number of people that should have undergone and been assessed as clinically frail, but we do know that of those who are coded as clinically frail, only a relatively small proportion of them are actually having the proactive interventions then coded, and that's what we need to address. We are working with ICBs as commissioners around how we identify outliers, how we address variation, how we increase the proportion of people, and we're putting some things in place to actually enable greater improvement support to get into practices where this isn't happening as it should be. There is an obligation of, so a huge proportion of the very severely frail patients live in care homes, and we do have, as part of the primary care network enhanced service, an expectation that primary care networks put specific interventions for enhanced care in care homes, including weekly ward rounds, part of multidisciplinary teams, etc. But we recognise we need to improve those things, and we're working with ICBs to do it.
Okay, we'll maybe come back to the care homes in a minute, but just sticking with the sort of core role really of the GP and identification and proactive care and the lack of that. It sounds to me like you put that responsibility with ICBs to do the contract management and oversight of GPs. Do they have the data to know who's doing it and who's not? And what are the consequences for those GPs who are not doing this? Because there are obviously consequences for those patients. They're more likely to end up in hospital.
So the ICBs do have the data, so they have access to the range of metrics and measures from individual general practices that we have, and we have a GP dashboard. There are no specific consequences other than identification of outliers and improvement support, but there are no financial consequences, for example. And we did take an approach over the past 2 or 3 years to try to reduce the number of individual targets that were financially incentivised within the GP contract.
Yes. So this is no longer incentivised positively?
It's not positively financially incentivised, no. It is counted.
Right, so do you think that's the reason why they're not doing it? Because they're not getting any payment relative to other
Well, it wasn't previously financially incentivised very specifically.
Right.
We have pushed GP practices very hard over the past couple of years to improve access, and unfortunately when capacity is constrained and demand exceeds capacity, which we know it does across general practice, then pushing to improve one aspect of care inevitably consequences appear elsewhere. But it's very important to us that, and it's in the 10-year plan and it's part of the medium-term planning framework, that actually increasing the focus on proactive care for priority cohorts is a priority.
I may leave it for you to come back, but I think maybe it's more for Jim. I mean, I've got a local GP who said their practice was doing really well with same-day urgent appointments, only 1 or 2 week waits for routine. Since digital access was sort of given a greater emphasis, should we say, that wait for routine appointments is now about 3 weeks, and they've actually had to reduce face-to-face appointments. We've said, government ministers are saying bring back the family doctor, want more continuity in general practice. For frail older patients, that is absolutely vital. If they have deterioration, they get in quickly, that they get continuity. This is actually reducing those opportunities. So how are you making sure that prioritising one thing, in this case digital access, is not actually harming the very thing that they have in their contract, which is proactive care for frail?
Yeah, absolutely. It's a really good challenge, and it's not acceptable, the position that we're in, first of all. We've had a lot of discussion this last couple of weeks about how we use the modern service framework to good effect to make sure that there's a clear structure that we expect everybody to comply with. And also then we've discussed before how we want to try and incentivise neighbourhoods to do what we want them to do and need them to do. So part of that consideration when the MSF is being finalised is whether there are incentivisation options that can make this work. But completely agree, it's unacceptable. It's central to the neighbourhood plan, so we've got to make really big improvements in this. and it's a key priority for all of us anyway, so it's going to have a lot of focus. It will have to be tighter in terms of compliance with the framework, transparency of the statistics, potentially, depending on the overall financial position and the other things that we've got to decide upon, some form of incentivisation also.
Okay, so the proactive care, I think, was 3 things: medication review, falls risk assessment, and an enriched summary care record. So the percentages are in the NAO report anyway, 16%, 18%, 29%. This seems pretty low, pretty poor levels of performance. Clearly, these are not just tasks for GPs. Potentially, we can get pharmacists doing medication reviews. I've even met with my local fire and rescue service who do safe and well checks in people's homes to try and prevent falls. So how are we going to make sure that within teams, whether it's the GP or others in the team, that those with frailty and recognised to have these risks actually receive what I understand is the evidence-based care that's going to really help them? I mean, evidence-based care, Chris, that's your... how do we make sure that, these patients are getting the care we know they need?
I'll start on, I know Amanda wants to come in as well. I mean, you're absolutely right that the first thing you've got to do is identify the issues. Now, let me slightly ride to the defence of my GP colleagues. I mean, a lot of people will have identified frailty without not having done so formally. That doesn't mean they reach the standard, but nevertheless, they will have picked things up and tried to act on them. But you're also completely right that something like, for example, a falls assessment is not something that necessarily will be done by the GP themselves. There are many other people who, in fact, are better equipped often to be able to do that, and a lot of it is about working out particularly as people move up the ladder of frailty, because frailty is not an either-or, it's a continuum, what they can do in their own homes, and that's absolutely critical. It's not an abstract thing. It's actually what can you do in the environment in which you as the individual, as the patient, live. So you're completely right, but you do have to identify the issue first, and that is the reason why early identification is important. Now, clearly, if someone bounds in at 65, having just come off whichever sport they enjoy doing, cycling, whatever, then actually someone's not going to do a frailty assessment. I think it's a fairly obvious point that those people are quite a long way away from that. But the further up you move in age, the more important that is. And to pick up the earlier point, particularly in areas of the country which have very large, increasingly large proportions of the elderly population, because this is not even across the country, I think that becomes even more important. And those tend to be the rural and peripheral areas, which often these are more difficult for people to come to their general practice because of distances, so you have to actually factor that in as well.
So I didn't mean by any means to criticise GPs,
no,
including those in my area who I think do a fantastic job, and I think the point I was making was they were doing a pretty good job of actually supporting some of the older, frailer patients, and actually sometimes inadvertently changes that are made can actually go in the wrong direction. And that it isn't all for the GPs to do. So I'm glad that you've made that point. But the point is that somebody's got to take responsibility, if it's not the GP, for making sure that those patients who do need or who are at risk because of increasing frailty are getting proactive care. So I suppose maybe just to finally push on that one, who ultimately is going to be accountable for making sure that these patients get proactive care?
So we've established a national frailty dashboard. The data for 26-27, which will be the first full year of it, will be experimental data, so won't be published, but we're collecting it and then we publish it. And that will take into account the range of interventions that we're asking ICBs to ensure are in place. So part of it is the GPs identifying, coding, putting proactive care in place. Some of it is asks around what happens at the front door of the emergency department if you turn up, and asking for assessment at the front door and interventions put in place that are appropriate if that person is moderately or severely frail. We are about to write out to ICBs as part of the framework for neighbourhood health with the key asks that they need to have in place next year around enabling better, more appropriate care for this population. We have commissioned an NIHR-led evaluation of frailty pathways and interventions, because what we need is more evidence about which of the interventions that actually make a difference for people rather than the whole list of things. And we've already established a frailty improvement collaborative, 7 sites, 1 in each region, looking at how we develop and scale, what improvement actions are most effective, and how we do shift care out of hospital. The commissioners, the ICBs, will be responsible for overseeing all of that happening.
I can see indicating both Chris and Sir Jim to want to come in on this, so if you're happy, I'll just let them come
briefly,
in.
We've got a lot of ground to cover.
Yeah.
Yes.
I think it's just to recognise that there are 2 ways broadly in which frailty tends to be identified. One is, in a sense, the ideal way, which is it picked up early in primary care. The other route is, in quite a lot of cases, it's actually picked up for the first time when someone goes into hospital with a crisis. And those tend to lead to slightly different immediate approaches. So if it's picked up in hospital, geriatricians and others will tend to pick this up and trying to reach into the community. Ultimately, we'll end up back with the GP, but a lot can be organised from a hospital. And then if it's identified in the first place by the GP, it's usually the GP who has the point to do it. But general practitioners, this is very central to what they do, and I think all GPs would agree with that.
And they do have the tools with the electronic frailty index, which is declaration of conflict. Some of the academics in Bradford, I think, were part of the team that developed the electronic frailty index, and they're very keen for me to always publicise that. So, yeah.
I'd agree with that, and also strongly agree this is a team endeavour. So when we've published the MSF, we will hold ICBs to account in terms of commissioning against the MSF.
The modern service framework.
Yeah, there'll be data to support all this. The data will be transparent. We'll be trying to hold ICBs to account and their neighbourhoods to account, but also at the hospital end, as hospitals are identifying frailty, there'll be processes we expect them to follow, and that'll be part of our overall oversight framework for them as well.
Okay, thank you. And hopefully maybe colleagues might pick up the point about care homes. I didn't get a chance to come back on that.
I'm sure we will. Can I just come back, Sir Jim, and take you to paragraph 3.13, page 36, and it says the percentage of residents who had a personalised care plan agreed, followed, or reviewed has fallen sharply from 76% in 22.3 to 44% in 24.5. This fall occurred when payments ceased for these activities, but GPs may still be providing this support and not recording what they're doing. I spoke to one of my local medical practitioners on Friday. One very overworked GP said, her practice had a lot of elderly people and she was just really struggling to provide these assessments. So will the ICBs specifically target resources to those practices and indeed areas? Professor Chris has warned about concentration of the elderly in certain areas of this country. Will resources be tweaked to allow extra frailty assessments to be made in these areas where there are a concentration of elderly people?
Okay, so there's a few things in that question. Amanda will rescue me when I get too far in. In terms of the overall resource distribution, in this year's financial reset, we've had a look at the allocation again through the normal mechanisms, and we're pretty confident that according to the mechanisms it's adequately resourcing our ICBs, and our allocation policy supports transition towards target over the next few years. So in terms of is the money going to the right place, broadly yes, from where we are. Now, on the incentivisation point, we know primary care is sensitive to financial incentivisation. It's a known factor that we've worked with in the NHS for a long period of time. And also, it's a finite resource, and we are constrained, as every system is, by a limit to the capacity. It has probably been the case in recent years that we've prioritised urgent access and some of the other things that have already been mentioned. We will consider as part of this next phase whether that needs to be rebalanced, and especially supporting the neighbourhood development also. So I can't guarantee it, but it's absolutely going to be part of the process that we'll go through to publish the MSF and agree whether it requires any new financial incentivisation. I think it's also, as an aside, more likely will incentivise neighbourhood teams rather than specific individuals in that process as well.
Please.
Right. there's a big variation between ICBs in the number of elderly people, percentage of elderly people who are actually assessed for frailty, and the percentage of people who are assessed for frailty who actually then get support. Why?
Amanda?
There is a big variation, and one of the means we use to improve things overall is to tackle variation and look at outliers, and we'll be particularly asking ICBs in those areas where there are negative outliers or particularly low numbers of people being assessed or offered interventions to tackle that. One of the things we've been doing over the last year, and we just last week published an update, is something called standardising community services. We have a range of community services across the country, not specified and described clearly, and so people code and measure and count in different ways and often fund through block contracts. And what we've done is publish, and we've covered now about 75% of all community services, detailed descriptors and coding, so that this can be standardised and we can properly compare across the country what's true variation and what's different ways of describing services and interventions. It also then gives ICBs the information they need to properly identify local need and to commission appropriately to respond to that need. And then we'll measure that with the frailty dashboard that we're establishing that I talked about.
So is it the ICBs who are responsible for putting these problems right?
The ICBs are responsible for commissioning services sufficient to meet the needs of their population. Obviously, there's a responsibility of all of the service providers to ensure that those services that they're commissioned to provide are delivered. So it's some of this is everybody's responsibility.
Well, sometimes everybody's responsibility
It
becomes
nobody's.
Yeah.
It does.
Right.
So I'm still not quite certain. I might come back to this a bit further, but the ICBs are responsible for commissioning the services, but commissioning things and making sure they're done aren't the same, are they?
It's part of the process of the commissioning cycle. So commissioning the activity includes understanding what's needed, but also ensuring that it's delivered by the people that you're holding contracts with. But this is, so it's a significant challenge for ICBs because general practice and community services have huge numbers of providers, sometimes at quite small scale, so it's slightly different from holding a hospital trust to account. But nevertheless, that's the process, and that's what needs to happen.
It's the ICB's job, is it, to rectify these inequalities that exist?
It's the ICB's job to recognise them, to ensure they understand the need of their population and to ensure they commission services to meet those needs. It's then the job of those providers who are commissioned and contracted to deliver those services to ensure they deliver them, and the ICBs will ensure themselves of that.
Well, it seems a very sort of divided process. Your ICB's out there, we'll commission what's needed, you get on with it, and it's not our job to make sure that it's happening.
It is their job also to make sure that it's happening.
The ICB will hold the people they have contracts with to account through their contractual mechanisms. It's a bit of a shift in our oversight frameworks. We will, in our oversight mechanisms, hold the providers to account as well. So, as CMO mentioned, some of this will rest in hospitals. We'll hold them to account in the quality metrics for their delivery of their aspects of the MSF.
Well, you probably know what I'm going to come to in a second about the ICB's ability with their reduced staffing and funding to actually do this work. If they're not doing it now, with 50% less staff, it's going to be a bigger challenge, isn't it?
So it is, but we've recognised, and we're doing some work with the ICB primary and community commissioning teams to identify the key actions we will need them to undertake to ensure that we're getting assurance about the things in the medium-term planning framework. And this year, for the first time, we've got some numerical targets around community services, as well as expectations about increases in capacity in order to enable both the proactive care we've talked about for this cohort, but the shift away from hospital. So ICB allocations do include about a 6% uplift in 26-27 and 7% the following year to increase community services capacity to start to do some of this work.
Well, we mentioned in our discussions the whole issue of integrating care at neighbourhood level. I had a briefing a week last Friday from the place, Sheffield Place, which is part of the ICB that relates to Sheffield with my MP colleagues. We got information about, I think it's an absolutely brilliant integrated health model at local level, which has been developed. Everyone joining in, GPs are the primary providers, the public health at the council, social care at the council, everyone working together. And I said to the acting chief executive of the ICB, what's going to happen from April when you've got 50% less resources? And they said, we won't be able to do this. This isn't our job, we're commissioning. We can't get involved in cooperation and collective working of this type. And I said, who's going to do it then? They said, oh, well, it'll be over to the council or the hospital trust.
I think the responsibility also sits with the ICB to ensure that they're part of putting the environment in place to allow providers to co-op.
Currently there are over 40 people at Sheffield Place working within the ICB. There'll be one from April. You can't do with one what you used to do with 40 odd.
You raised this last week, Clive.
I did, yes.
We're in the process of picking this up specifically with this ICB. The way you describe it always makes me feel like we've got ICBs post-change that are three men and a dog. They're still very large organisations. What we've agreed with colleagues is that we're reprioritising. They are shrinking, but we're reprioritising some of their activities so that they can do these things. So the response you've got is completely inadequate, and we are in a process of discussing that with the ICB.
I just can't believe it's the only place in the country, you see, because if you've got an organisation, you suddenly get rid of 50% of the people, the tendency is to say, well, we've got these people in a local level place, we'll pull them into the centre because then they can do everything for all the places. That's what's happening.
You are dealing with it in different ways, so not all are doing that. I accept a few have been highlighted that have been going that way. But that's not the intention. We'll pick it up specifically with that ICB.
But just ask Chris Whitty, because I remember, Chris, you came along to the PSC session where we just had the announcement of the changes. And I think you were saying then that the important thing of the changes, and I asked you the question, was to ensure that there were resources at place, because that's where the real links with social care and public health were going to be. Are you happy that's working?
Well, at that time I had the dubious privilege of being the interim permanent secretary, so I was answering those sorts of questions as best I could as interim permanent secretary. So actually,
the answer no. What's the answer no?
But I mean, broadly, I mean, I think all of us here would agree, as all you would, that actually having the resources to be able to deliver the services is critical, and it's really how they're best distributed. But as I say, that is now no longer a CMO job, unfortunately.
So luckily, I have the privilege of being the substantive permanent secretary for the Department of Health and Social Care to be able to answer the question from CMO. So I think we recognise, and we've talked about this before, and Jim's picked up specifically the case that you mentioned, that as we go through the change, there are some very clear statutory responsibilities that the ICBs need to be delivering. The oversight framework and the planning framework ICBs are responsible to be able to demonstrate to NHS England what is happening at all levels, including, if I may, on the outcomes that they are responsible for commissioning through this process. And it's the outcomes that make the difference rather than the input. So the point that Anna made around the teams, I think, if I may, just around the numbers of people, notwithstanding the specifics that you raise around that ICB, I think there is the dashboard that Amanda talked about. There is the data set around community services, is making sure that people are using the dashboard to understand where and how services are being delivered. But this goes to the heart of neighbourhood health and neighbourhood care in terms of how we are ensuring people are kept as safe as possible in the places that they should be. The answer to your question is through any programme of transition, as we are at the moment, through the abolition of NHS England, the Department of Health and Social Care, is very tight monitoring on what's going on the statutory responsibilities of the ICBs. Specific cases that, such as the one that you mentioned, Jim's picked up outside.
Right. Well, I think I'm getting an assurance that Sir Jim will be coming back to me on those specific issues and concerns, because I think we can all see this could go in a very wrong direction. Yet what we want to achieve is this integrated care. And in Sheffield, we've actually got really good relationships historically between the NHS and the council. They do work together, and that's important we keep that.
Oh, absolutely. Yeah. We'll come back to you when we've got answers on the questions.
Yes. And the GPs are all signed up as well. That's it.
Yeah.
Thank you, Clive, very much. Thank you. Sarah Olney, please.
Thank you, Chair. Just coming back to the question of care homes. So we know, because the report tells us, that the number of residents who've got a personalised care plan in a care home has really fallen. It was 76% in 2022 to 23, and it's now only 44%. And the report notes that the fall occurred when specific payments ceased for these activities. So it might be that it was being recorded in order to get the payment, and it's still going on, but it's no longer being recorded because there's no payment associated with it. But what... So Jim, why would you say that the percentage of care home residents with a personalised care plan has fallen? And is that something you're concerned about?
I am concerned about it, but Amanda, I'm sure will answer the question.
So the Enhanced Care in Care Homes programme is part of the GP contract through the Primary Care Network DES. So practices are obliged at a network neighbourhood level to deliver interventions into people who live in care homes, who are clearly the most severely frail group of our population. Part of that is about being part of multidisciplinary teams, about weekly care home ward rounds, about moving so that you don't have 4 or 5 different GP practices all coming into the same care home, so it's much easier for communication and ward rounds and things to be managed by care homes and the GPs they work with. And then there are a range of asks that were coded separately and specifically, which originally did include care plans, but that was narrowed down during the 23-24 year as part of a move to have less tick boxing and more guidance about service provision as part of the GP contract. The result of, well, maybe not the result of that, but associated with that timescale, we have seen a significant reduction in the number of care plans coded. But in the 10-year plan, there's a very specific commitment to the people who will most benefit from personalised care plans getting them, and so there will be a push to address that.
What assurance do you have then, if for whatever reason their data is no longer showing that sufficient people have got these care plans, what assurance do you have that GPs are delivering that part of their contract and that care homes and their residents are getting the support that they need?
We have assurance that the enhanced care and care home specific measures, such as ward rounds, for example, are happening. But what we don't necessarily know is whether, as you say, the care plans are still happening, but nobody's putting the code in because we don't specifically count it anymore, or whether they're just not happening. Part of the evaluation of the specific interventions around frailty will help us understand that, but we have got a commitment to increase personalised care planning for a whole range of cohorts of the population, people with long-term conditions, for example, people at the end of life, as well as the most severely frail people. And so we will be putting processes in place as we develop the 10-year plan delivery to ensure that we can record that that's happening.
So you've sort of stopped measuring it, or you've stopped the kind of the incentive to measure it, but you'll be bringing it back again. Is that what you're saying?
We stopped the mandating of coding and counting as part of the contract. We never removed the guidance which suggested that was what should be happening. But as we look through 10-year plan delivery to roll out personalised care plans to a much bigger section of the population, we are going to have to look at how we code and count those. We talked a bit earlier about one of the interventions we must offer for people who are severely frail is an enriched summary care record. And part of what makes it an enriched summary care record is that care plans are available and accessible on that care record through the spine to any clinical area such as the emergency department or a same-day frailty service that patients might present. So it's really important that not only do we code them, but we have those plans accessible through the care record.
I mean, that's for anyone with frailty. You're not specifically looking at people in care homes at the moment. I suppose what I'm asking is, obviously GPs have got the responsibility, and that hasn't changed, even if, as I say, the incentive to record that specific care plan has. But is there not more that GPs can be doing to because obviously, by definition, if they're in a care home, they must be frail or at risk of frailty. Is there not more that GPs could be doing to target those residents and ensure that they are being properly looked after?
So those residents are a subset of the cohort with moderate or severe frailty. They're almost all severely frail in one way or another. And so the enhanced care in care homes services are not just GPs. So there's an obligation for GPs to be part of them, but that's part of multidisciplinary teams. And there's quite a lot of interventions. Some of them are the community services interventions, for which we've set targets around weights now. So if you are already frail, then poor hearing or feet that aren't managed and so making mobility difficult, or lack of occupational therapy input, all of those can contribute and worsen your frailty. So all of those things are part of what this enhanced care for the frail population, including those in care homes, include.
Thank you. Thank you, Chair.
Thank you very much, Sir Lake. Stephen.
Thank you, Chair. So GPs are contractually responsible for identifying and supporting people with frailty. Of course, these contracts are costing us all a great deal of money. So why does NHS England, I think this is probably a question for you, Sir Jim, not set performance targets for GPs to identify and provide support to people with moderate or severe frailty?
Yeah, it's a good question. Amanda actually is the expert on this and leads on it. But generally it sits within, it's a separate contractual negotiation. And there's always a lot that colleagues want to achieve from those contractual negotiations, and it's never possible to achieve everything that is wanted or desired. And in that, we've got to be careful on the earlier point to not do something that overcorrects and causes another problem. It's really quite finely balanced how we direct the GP resource. But Amanda,
did you want to add something?
I think that's right. I think, to be fair to general practice, they have a wide-ranging contract that includes all of the reasonable needs of all of their registered population. Obviously, a significant proportion of demand on GPs comes from the sickest people, who are the moderately and severely frail population, but there's a whole range of things we ask of them, and we have to balance a contract where they can use clinical judgment and prioritise according to the need of their registered list versus one where we measure and count every single intervention. And we try to balance that. And sometimes what we do is financially incentivise interventions in order to make the change to the way GPs work for a period of time, and then those things are part of the wider expectation. But of course, our main financial incentivisation in the general practice contract is through the quality and outcomes framework, which largely measures specific interventions for specific long-term conditions. But of course, the people who are most severely frail are often the very people who suffer from more than one of those long-term conditions. And so we are measuring very specific interventions which not only delay the onset of frailty, but actually prevent and delay deterioration of frailty in combination. It's just that we haven't put a label of frailty on those measures. We perhaps might be looking at blood pressure, or we might be looking at diabetic interventions or others.
Recognising those challenges, and I do recognise those challenges, without setting targets or monitoring compliance in a specific way towards frailty, how can you know if patients are getting the services that they're entitled to? And I suspect it's a complicated answer.
It's a very complicated answer. We have a GP dashboard, and this is just speaking about general practice services rather than all the other contributors to these services. We have a very wide-ranging dashboard which measures a huge range of metrics, everything from the number of staff that are employed to the number of appointments that are offered, to access rates, to clinical quality outcomes, to these sort of numbers that we've talked about today. What we tend to do is look at people who are outliers, negative outliers, on several indicators. So there's always going to be one thing that a practice doesn't do as well as it does other things. But what you actually get down to is very small numbers of practices when you start to look at grouped outliers, and that's how we tend to address those who most need improvement support. And we are taking measures to actually give commissioners a better ability to ensure that the improvement support is accepted and is able to be put in practices.
So how would you know when to intervene? So, for example, just 10% of the population of Bedfordshire, Luton and Milton Keynes ICB area, which serves my constituents, age over 65, were assessed for frailty in 2024-25. Now that sounds like a very low number. I'm sure you will know where that sits compared with other ICB areas. So without sort of performance targets for GPs around frailty, how do you know whether that ICB area is doing better, worse than other ICB areas? And how do you know whether to intervene or not?
So I will look at it by ICB and identify the ICBs where numbers seem to be low and address those through our regular assurance meetings with ICBs. I would expect each ICB to be looking at that at individual practice level and addressing those outlier practices, because even within an ICB we often see quite huge variation in performance. Some ICBs do that to a greater degree of detail than others. 10%, that we've got a group that are at 10% or lower, and they're the sort of the lower end of the performance.
And so in that example, given that that's my ICB area, what would you be doing to improve performance in that ICB area in this scenario?
So in this scenario, in our regional performance and assurance meetings, we would be flagging these ICBs in your region look as though they are lower than comparable ICBs, and we would expect those ICBs to take measures to identify the reasons for that. And the reasons will be different in different places. As Chris says, some places have real challenges around a higher frail population or difficulties attracting workforce. In others, it may not have been focused as a priority in the way that we'd want to see it.
Yes.
Can I add just a note of scepticism into this? I think the correlation between GPs who fill in all their forms and GPs who provide an excellent service to their patients is a long way from exact.
And I'm sure. And
in both directions. I mean, all of us would want them to be doing the assessments, whether formally or slightly less formally, and ideally all of us would like them to be writing them down. That's particularly true because there's much less continuity of care, back to a point that I think the Chair made right at the beginning. When there's continuity of care, you don't need to write things down as much because you know, but if there's a lot of moving around, actually having it written down does have clear advantages. Nevertheless, I think we shouldn't assume that working to the contract equals good care. That's unfortunately, not even unfortunately, that is not the case.
Yes, which actually brings me to my final question, because what's important, I think, is all of our constituents' quality of life. You know, so taking this as a whole and sort of stepping outside of the dashboards and the metrics and the performance measures, how do you ensure, as NHS England, that you're really focused on our constituents' quality of life?
So, I mean, Chris has mentioned continuity of care. Continuity of care is vital, and it is more vital for this group of patients than it is for most, because the balance between remaining independent at home and having admissions to hospital that aren't actually going to benefit someone, a conversation with a trusted clinician is often what makes the difference there. One of the things that we are measuring in our monthly HIS surveys that the ONS carry out for us is continuity of care. We're measuring it in the form of do you have a preferred clinician, and were you able to see that clinician? Because that's probably where it's most meaningful for patients. And we are seeing that slowly but steadily improving. So at the last count, it was about 67% of patients who'd had contact with their practice in the previous month were able to see their preferred clinician. That's really important for this cohort. And we are able, if we've got enough data across enough of a wide area, to actually identify whether specific cohorts of patients are able to see the preferred clinician. To get that at practice level, we can only really do that with the annual GP patient survey that gives us much more granular information.
Chris?
I mean, just to add to that, but answer the question in a slightly different way, complimentary, I hope. And I'll give you there's a striking statistic in, I think, figure 2 of the NAO report that shows that at, for example, 90, age 90 and above, 2/3 of people in the most deprived quintile have frailty, and 1/3 of people in the least deprived quintile have frailty. The difference between those is clearly not biologically inevitable. So actually the most important thing, even better than picking up frailty, is to actually prevent it in the first place. And so really doing all the things that can be done along the life course that will make frailty much less likely, because if you take that top quintile in terms of socioeconomic deprivation, the least deprived, that's really, we should be aiming for that for everybody, in which case, even in your 90s, the majority of people will not be living with frailty. And that really is something I think we should see as the most central response to this.
Thank you so much.
Perhaps, Professor Chris, figure 3 is even more important. This is a projection of the number of elderly people, the increase in the number of elderly people, which will make the need for all of these frailty services even more acute, will it not?
That is exactly true. But if you put the two together, what you see is that actually the frailty levels in the areas of deprivation are roughly 10 years earlier than for those who are actually living in the areas of affluence. If we could get everyone close to that 10-year difference, you can actually make up the difference between those two. So that is really important that we do that. And I think there's always an assumption that an older population inevitably means a frailer population. Actually, there's a lot we can do to reduce that, and I think that really should be central to our planning here.
Particularly early intervention.
Yes, all the way through. It's not something you wait till you've got the first crisis in hospital. You've got to do it much upstream of that.
Thank you. Rachel Gilmore, please.
Looking at the statistics that we've all been provided according to our constituencies, mine is particularly bad, as always, partly because I've got a higher population of deprived elderly people, but the lack of intervention by GPs and therefore a poor reflection on the ICB, I wonder whether than just measuring things by metrics and IT, if there could be any suggestion that should be more accountability for ICBs, because I don't see it. If one was a poor performing school or a poor performing local government authority, there would be something called special measures. And I'm afraid to say, had very strong words with Somerset ICB, who are one of the worst performing in the country. Would you be prepared to take on something like special measures for ICBs that are performing so badly?
I'll make just a quick comment on your constituency, because I've had the privilege of being there, and I'm aware.
Coming back.
Well, let me start off with that, and then really turn to Amanda for the second bit. One of the things which they made very clear to me then, and I don't think it has changed since, is the difficulty of attracting GPs to go and work in there. It's an amazing place to live, as you know, but also there are structural reasons why it is difficult to get primary care, nursing, and other things that we all need for frailty, social care as well, in many of the areas where the rates are highest. And I think those are something which collectively we do need to look at quite seriously.
I take that on. I would make absolutely no criticism of my GPs or my nurses. And just to let you know, the very good news is that because the medical centre in Minehead is now seen to be improving and getting satisfactory, we have actually recruited 2 new GPs in the last 6 months.
And the GPs I've met, to be clear, were excellent. It's just that it's getting people in the front door. Amanda, over to the...
So that's right. The better you get, the more you're able to recruit, and things improve even more. We do have an oversight framework nationally that we monitor not only trusts and providers, but also monitors ICBs, and there are a range of outcome measures we use, and there are processes where ICBs aren't delivering.
And on that, we've started very much at the provider end, within providers, the hospital end, where there's more data. This year we'll build out the commissioning oversight framework. It might be worth, Chair, just coming back as a specific item and talking about the oversight framework, because it does underpin an awful lot of what we're trying to do.
It's particularly acute at the moment because Somerset, of course, is being merged into the broader Wessex ICB, and I think an overview of Somerset as it is now would be useful as it feeds into that wider ICB, not least because they're retaining the Somerset CAO for the Wessex ICB.
Yeah.
Thank you.
Done? Good. I've got 1 or 2 questions. Amanda, I have this sort of vision. I hope I'm wrong, and hopefully you'll be able to tell me that I'm wrong, that there are a lot of moving parts in all of this. There are hospices, hospitals, local care, GPs, a whole range of people. And when an incident occurs, like a fall, who coordinates that person's data to make sure that that's followed up? So it might, for example, happen in an elderly person's home, it might happen in their own home, it might happen while they're out on the street, but somebody, that person may end up in a GP surgery or in hospital. Somebody needs to follow that up, and it needs to be a properly kept database so that all the different bits of the system that might interact with that patient are aware of what's happened.
So whatever interventions are carried out in various NHS providers, so for example, that all of that information enters the GP electronic patient record. So that's the one place where at the moment we hold everything. And that would include, for example, if an ambulance service went out and even if they didn't take the person to ED, there'd still be a record. And then you would expect, as part of proactive care for this cohort of patients, the GP practice would follow up. One of the things we are doing as part of the single patient record, which we talk about in the 10-year plan and which we are developing, moderate and severely frail patients are one of the first use cases for the single patient record because it is so important that the information is brought together in a form that everybody understands what the care plan and the process for that patient is.
Thank you for that. Can we talk about neighbourhood teams and funding thereof? So a lot of this funding comes, as we've already said, it comes partly funded from NHSE, ageing well funding, ICB funding, local authority funding, voluntary and third sector groups. Who makes sure that this funding is really effective at dealing with this problem and assessing whether people are moderately or severe frail?
So the ageing well funding specifically isn't a specific fund anymore. So that was in place from 2019 to 2023-24. It's now part of ICB allocations to mainstream some of the services it developed. We are, as part of the Neighbourhood Health Implementation Programme, looking at the integrated neighbourhood teams. We are asking ICBs to start developing neighbourhood services by focusing on some priority cohorts, one of which is people who are severely frail or at the end of life. And we have increased the relative size of the allocation to ICBs for community services compared to acute services, for example, so that they're able to start with those first asks. But alongside that, there's significant work being done looking at payment models and financial flows, because ultimately what we need to do is look after patients in the community and in their own homes and fund, rather than looking after them and funding hospitals to do it. We need to ensure that funding flows into community teams to give them the capacity they need to address that. So
the next problem I have in my mind is that a lot of this care is provided by social services. The whole idea of creating ICBs was that the health service was going to work better with social services and the local authority. But I wonder whether with this shortage of staff in the ICBs, that this is one area of work, as Clive's already hinted at, that not just in Sheffield, but right throughout the country, that is going to really suffer. And a lot of this, assessment at home, falls, and so on, needs to be assessed by social services, but if they're not either there, and I've only got one district nurse in the whole of the Cotswolds, North Cotswolds, how is it going to be done?
So one of the things we are encouraging or creating the environment to happen is that local authority social services providers are working on a neighbourhood basis developing these services. Some of it is about assessments. Some of it is about domiciliary care support to allow people to stay at home while they are less well. And often I was a GP for about 25 years, and in my experience, the thing that made a difference between having to call an ambulance for someone or being able to look after them at home was whether you could rapidly get a domiciliary care package in to somebody's home to enable them to stay at home when they were less mobile or had an infection or had deteriorated. And so it's absolutely vital that teams do this. But we know from the National Neighbourhood Health Implementation Programme that the sites that are testing and developing more quickly in these areas, these are the things they are doing. They are working to identify the interventions that make a difference for priority cohorts, which particularly includes how we work with local authorities, social care providers, to make sure that we keep people independent. And some of that's about discharge processes from hospital, some of it's about payment flows to enable that to happen, as I say. Some of it's about single points of contact to enable care coordination for care providers and communication.
So we've had a real problem with people being discharged from hospitals. It's got better, but the lack of domiciliary care packages is a major part of that. As I said, quite thinly on the ground in Gloucestershire, and I suspect as in Rachel's area, these rural areas, these social services are very thin on the ground. So what do you do in the health service, in your department, to actually help ICBs where there is a real problem with the provision of social care?
One of the challenges we've got, and rural areas is a prime example, if the distance to travel between care visits for domiciliary care providers is greater, you need more staff and it becomes more difficult, and you have less of a pool of people to pull on. It's really important that NHS services and local care providers are not all sending people into the same home in an uncoordinated way. So some of the work we're doing is looking at what are the interventions that can be offered generically, how do we coordinate and share information so that people are getting the best support they can get. So for example, you don't need a nurse to go and check a blood pressure. If you've got a healthcare support worker going in, they can do that at the same time as they're going in to provide a care package. We have people offering supervision around things like medication in the home, and we need to much better integrate what the NHS is providing with what local authorities do. The Better Care Fund should enable that to happen, and we're looking at how we almost refresh our approach to using those funds that are in place to commission jointly between health and social care in local places. But we can't sit here in the centre and micromanage that in every individual area, because how you need to approach it will be very different in the Cotswolds from in Blackpool.
I hear what you say about what should happen. Yes. I think it's pretty difficult in the North Cotswolds. Anna.
It was just a very short point. We've been hearing about the reform of Better Care Fund. You mentioned it again, a refresh, a reset. When can we expect to see the details of what you're actually proposing? Or have I missed it?
Very shortly.
Yeah. Okay, it just underlines the point that the whole point of that was exactly to target this population, and it's generally, obviously, that money has got diverted into providing core adult social care due to the financial straits that local authorities are under. So clearly how that gets targeted better at this cohort, I think, will be very important.
I wasn't being facetious, and it's a very live discussion at the moment, so I was responding very shortly, more seriously than it came out.
That's fine. We sometimes like short answers, don't we, Chair?
We do. We like short questions
short
too.
Short questions too, so there we go.
Let's finish on a little bit more positive note, on a rather depressing hearing, and I do repeat to you all, a mark of a civilised society is how well it assesses frailty, and I'm not sure that I've come out of this session with terribly bright prospects in that respect. But let's finish on one positive note. Maybe Professor Chris, virtual wards. The department's putting a lot of emphasis into virtual wards. They do look as though they might be able to produce some positive improvements. Do you just want to talk about that?
So I'll give a sort of clinical view. Sir Jim may want to give some views about how it works for the service, but where for the right patients, a virtual ward possible at home, there are a variety of ways of describing them, can be a much better outcome. They're in a familiar environment, particularly for people often with frailty, with early dementia and other things. Being in a familiar environment makes it a much better place for them to be. It deals with many of the issues that you hinted at earlier on in terms of beds, because they're in their own bed. The thing which we always have to remember is that they do require people. So if you don't have enough nurses, doctors, physiotherapists, occupational therapists, it doesn't matter whether it's a hospital or it's in a virtual ward, you're still going to be unable to provide the full care package you'd want to do. But for the right people, they can make a remarkable difference. They're not the right thing for everybody. If someone's very unstable medically, you definitely would not want them in that setting. You need them in a setting where you can get to them very quickly. But for many people, particularly if they're in what in old-fashioned terms we'd call convalescing, they've had the acute episode, now they've got a period of recovery, a virtual ward can be a very much better place to be.
Anybody want to add?
Well, I would agree. I agree with that, and I think you can see the service finding more and more examples where we can augment people's care at home and prevent hospitalisation. As Professor Whitty's just described, what we saw in West Herts and what I saw last summer is absolutely amazing in that regard. It's scaling it up in a systematic way. That's tricky.
And finally, can I just ask you, Professor Chris, are we over-medicating elderly patients? And therefore, doesn't the part of this frailty assessment, the medical review, is really important? And there is a statistic which I was looking for, which I can't find quickly, of the amount that it costs by people, the interactions between over-medicating, and that's why these regular medical reviews are important. What more can we do?
Yes, I mean, with the slight caveat, I don't want anybody listening to this suddenly to say, okay, I'm going to throw away all my pills, because there are obviously a lot of things you can usefully do. But absolutely, if you ask any geriatrician or experienced GP dealing with people in older life, what will have happened is they'll have acquired one pathway after another, each one of which makes sense individually, but the combination gets to the point where actually they're probably the number of side effects is actually causing problems, and certainly the benefit to that individual has now passed. So one of the most important things you can do in that situations is rationalising down to those drugs that are actually improving quality of life, rather than having a very long list of things which are probably very unlikely to achieve that. So, yes, of course, there are many people who need to be on many medicines, but there are many people who need to shrink the number down quite significantly.
One of the things we're doing about that to actually enable us to actually review the patient's medications and reduce them where it's appropriate. So most primary care networks now have pharmacists as part of the team who are able to go out, see patients, do structured medication reviews. We are looking to step up the clinical service provided by pharmacists rather than being a largely dispensing service. And we've got a benefit in that from this year, all graduate pharmacists will graduate as independent prescribers. Now, you have to be a prescriber to start medication, but you also have to be a prescriber to stop it. And so what we hope now is that pharmacists will be enabled not only to see the record, to have the time to do proper medication reviews with people, but will then be able to stop medication appropriately and monitor the patients as that's stopping. So we're hoping that the role of community pharmacy and pharmacists in that process will really enable us to make changes, because it is one intervention that reduces your likelihood of being inappropriately admitted to hospital.
So we've had evidence from the pharmacists. They'd love to do all of that work, but they say they're not funded enough to do it. So there, well, I leave you with that problem. So can I thank all our witnesses this afternoon? What's been a slightly difficult hearing. I suspect it's something we're going to come back to, because I think we need to see it working better. But anyway, thank you very much for your time. An uncorrected version of the transcript will be available in the coming days. We, as you know, will be producing a report with recommendations, which we hope you'll look at seriously. Thank you again for coming. Order.
Thank you.